Okay, hi everybody, and first of all, we wanted to thank you for joining the webinar today. And first of all, we hope that you and your families are well and keeping safe during this very difficult time, as we're all attempting to navigate really the COVID-19 pandemic. Second, we wanted to welcome and we thank all of you for taking the time to join us for the Discover Alliance virtual town hall panel discussion today. I also wanted to introduce our panelists, and we have on our panel today, we've got Kelly Thompson, for CEO of the Strategic Health Information Exchange Collaborative, Scott Stewie, CEO of Direct Trust, Paul Wilder, Executive Director for Commonwealth Health Alliance, Chuck Jaffe, who's the CEO for Health Level 7, Dave Castle, Director, Care Equality and the Sequoia Project, and John Rancourt, Director, Interoperability Division, the Office of Policy, the National Coordinator, ONC. So that's our panel today, and you're not seeing me on your webinar because all of you know that it's called the principle where things you hoped would not happen occur, where your computer basically shuts down and decides to do software updates while you're in the middle of joining a webinar. So that's what happened to me twice. So that's why I'm not on the webinar. So sorry for that. I also wanted to, I know that you've got kind of the first slide. I assume that's up, Carol, right now. And what I'd like to do is to go to the next slide, which I wanted to take the opportunity to thank Discover Alliance for hosting this webinar, and also all of our sponsors, Answers Media Network, Zen Health, Cerner, and EFAX Corporate. Without your sponsorship, we wouldn't have been able to have this webinar, so we really appreciate your sponsorship of our town hall meeting. So let me go to the next slide, which is our agenda. And one is to obviously to welcome all of you, and we'll be going through our panelist introductions in a moment. Each of the panelists will be providing opening remarks. Then we'll have a panelist Q&A, and you can submit your questions down on the bottom right hand of your screens as far as the navigation panel. You can type in your questions there. We'll try to get to your questions and try to answer as many of them as we possibly can. Then we're going to be getting the Discover Alliance overview from Jenna Yost, who is the interim president for Discover Alliance. And then an iNavigator, the tool that Discover Alliance has, and talking about and showing you some of the screenshots of what that tool can do. And Vince Albanese will be going through that with you. And then we'll close. So what I wanted to kind of start off with is basically as we're all aware with, every segment in the industry within healthcare is in the process of really discussing 21st Century Cures Act and TEFCA, the new approach to healthcare interoperability today. Organizations need to understand how to participate, what it means, how they're impacted, and how to be compliant stakeholders on the healthcare digital highway. We're going to also be discussing, how our current and future interoperability ecosystem is facilitating data exchange in light of the COVID-19 pandemic. So the session we're going to have will cross industry segments. We're looking for this to be a very interactive, engaging experience for all of you. so that you can have your voices heard as well as any questions that you have answered. We're going to be doing polling during this discussion as well, and we'll share the results with all of you as we proceed. And you can submit questions, as I mentioned, at any time, and I'll mention it several times, so please don't hesitate to type in your questions and we'll try to get them. The session is going to be recorded, and so you'll have access to the session afterwards, as well as you'll have availability to the slide deck that we'll be having should you wish to reference it as well. So with that, let me go through and introduce our panelists to you. So first is Dave Castle. Dave has worked for more than 20 years in the healthcare information technology, creating a national reputation as an expert in health information exchange. He, as Vice President of Care Quality, he's responsible for the Care Quality Interoperability Framework, which enables health data sharing across and among different types of networks. Under his leadership, the national level trusted exchange framework was first implemented in July of 2016, and the framework rapidly expanded to support exchange among more than 260,000 providers across more than 850 hospitals and 20,000 clinics in less than a year. So that's Dave. Let me go over to Chuck Jaffe, who's MD and CEO of Health Global 7. He serves as the organization's global ambassador, fostering relationships with key industry stakeholders. He's a 37-year veteran of the healthcare IT industry. He was previously the Senior Global Strategist for the Digital Health Group at Intel. He was Vice President of Life Sciences at SAIC. And Chuck, I was going to tell you, we're both alumni of SAIC. And he was also Director of Medical Informatics at AstraZeneca Pharmaceuticals. He completed his medical training at Johns Hopkins and Duke Universities, and was a postdoctoral student at the National Institute of Health and at Georgetown University. He was also formerly president of Informad at Informatics Consultancy for Research Informatics. He's been contributing editor for several journals and has published on a range of subjects, including clinical management, informatics deployment, and healthcare policy. John Rancourt, next, serves as Director Interoperability Division, the Office of Policy for ONC. The Interoperability Division supports health IT policy implementation through such activities as the Trusted Exchange Framework and Common Agreement, state and Medicaid interoperability efforts, public health, including the opioid emergency, value-based transformation enabled by health IT, consumer engagement and data access, engagement with behavioral health, EMS, and long-term post-acute care providers. And during his career in health policies, John has also worked on Capitol Hill as a patient advocate and journalist. Kelly Thompson is the CEO of Chic, and she's responsible there for working collaboratively with their members and board of directors to develop and actively advance an organizational strategy that ensures Chic's success. Her goal is to elevate awareness, stature, and perception of HIEs on the national healthcare landscape. Before she joined Chic, she was Deputy Secretary at the Pennsylvania Department of Health, and while there she created a long-term care partnership in care delivery and oversight. And under her leadership, the eHealth partnership achieved statewide connectivity, offering electronic health information exchange in every county of the Commonwealth. She also co-founded and led the Commonwealth's Privacy and Security Practice Group as well. Prior to that, she was a senior advocate of policy and regulatory matters for the Hospital and Health System Association of Pennsylvania. And in that role, she advised providers on health policy, regulatory, and legislative matters. She established the annual organ and tissue donation hospital campaign and was a primary drafter of the Commonwealth's deemed status legislation aimed at ensuring timely standards for healthcare facility oversight. The next individual I wanted to introduce is Scott Stewie, who is President and CEO of Direct Trust. Scott is a 25-year veteran of the healthcare information technology industry, and as President and CEO of Direct Trust, Scott drives visibility and utilization of the Direct standard to contribute to nationwide interoperability. Under his tenure, the organization has achieved landmark milestone of 1 billion direct secure messages sent and received over the Direct Trust network, which is quite an achievement. Previously, Scott was Director of Strategy and Interoperability at Data File Technologies, a health information management company, and served more than 25 years at Cerner, including Cerner Network's Director of National Interoperability Strategy, where he facilitated participation in the Commonwealth Health Alliance and the Bridge with Care Quality. And finally, Paul Wilder, Executive Director of Commonwealth Health Alliance, is leading the organization as it enters a new chapter in its pursuit of empowering clinicians, practitioners, and individuals with interoperability services via its robust nationwide network. With more than 2 decades of experience in health IT, Paul has held various roles focusing on imaging, clinical informatics, and interoperability. Prior to joining Commonwealth, Paul was Vice President of Strategy and Business Development for Philips Interoperability Solutions. He also spent close to 10 years with one of the largest regional HIE networks in the world, the New York eHealth Collaborative. He served as its Chief Information Officer, Vice President of Product Management, and Program Director for New York eHealth Collaborative Regional Extension Center. And during his time with NYEC, he also helped nearly 10,000 primary care providers attest to meaningful use and solidify the state's status as one of the national leaders in health IT adoption. Each role has really enabled him to work directly with providers and end users of electronic health records and gives him an important perspective as a leader in health IT adoption and execution. So that's our stellar panel, and I'm very, very pleased that all of them were able to participate on this panel today. So what I wanted to do is to talk to you, and so Carol, if you can go to the next slide on my introduction. I'm going to take a couple of minutes just to try to put in perspective for all of you where we are and hopefully kind of talking about where we're going, especially the fact that now we have the 2 new rules that we've been waiting and anticipating for quite a long time. And those rules came out as of March 9th, just prior to when HIMSS was going to start. And they're focused on interoperability and patient access final rule and the ONC information blocking rule. All of them focused on really putting patients first, giving them access to their health information when they need it most, and in a way that they can best use it. Some of the other aspects, of the final rules include privacy, security, and standards. And in this one, really, CMS partnered with ONC and identified Health Level 7, the Fast Healthcare Interoperability Resources, or FHIR, Release 4.01 as the foundational standard to support data exchange via secure application programming interfaces. The other is the Patient Access API. So this allows patients to easily access their claims and encounter information, including cost, as well as define subset of their clinical information. And so, again, another component of this. And then you look at the Provider Directory API, Application Program Interface, and again, this is another one where CMS regulated payers are required by this rule to make the Provider Directory information publicly available. And then payer-to-payer data exchange, again, CMS regulated payers are now required to exchange certain patient clinical data, specifically the U.S. Core Data for Interoperability, or US CDI, version 1 data set. And then there are other components such as the improving dually eligible experience, by increasing frequency of federal state data exchanges, public reporting and information blocking, digital contact information, admission, discharge, and transfer event notifications. So these are some of the aspects that are part of the rules there, and obviously there are many hundreds of pages to the rules that I'm sure all of you have spent a lot of time reading, and I know many of my peers on the panel have as well. So in an effort to provide all of you kind of with a perspective on what all this means, let's start by answering the basic question on how do we get to this point in relation to interoperability. We know we need interoperability, and we're working very diligently with the industry and certainly with ONC and with the various players here to implement and move past some of the issues that we've had with interoperability. I'm going to talk about some of those. So let's talk about some of those factors as the biggest barriers. So according to kind of the most recent ONC report in 2018, there were 3 major barrier categories. And over the past 10 years, the use of certified health IT has become widespread among providers. However, only half of office-based physicians are electronically exchanging health information with healthcare providers outside their organization. And healthcare providers' abilities to find or query and integrate information from outside resources is really lagging even farther behind. So some of the barriers to interoperability to continue to limit access and use of electronic health information, including some of the technical barriers, such as a lack of standards, development, data quality, and patient and healthcare provider data matching. There's financial barriers around the costs of developing, implementing, and optimizing health IT. And some of those barriers include lack of sufficient incentives for sharing information between healthcare providers and the need for enhanced business models for secondary uses of data, and the current business models for health systems or healthcare providers that really don't adequately focus on improving data quality. And then we have some trust barriers as well, legal and business incentives to keep data from moving present challenges. So those are some of the barriers that we're continuing to focus on, and I think the rules are certainly attempting to address. And then in the 2025 Federal Health IT Strategic Plan that came out not too long ago, which really focuses on 2020 and 2025, there were a number of specific goals that they focused on as well. And some of those goals included advancing the development and use of health IT capabilities, which we're going to be talking more about, establishing transparent expectations for data sharing, enhancing technology and communications infrastructure such as broadband and cloud-based usage, and promoting secure health information that protects patient privacy. Basically, integrating privacy and security into design and the use of health IT and really increasing patient understanding. So those are some of the kind of the components that I thought would be helpful as kind of a backdrop and background as kind of where we've been, where we are today, and certainly we're going to be talking more about kind of where we're going as far as this digital highway with the panelists. So with that, the next individual we're going to have kind of giving their opening remarks is Dave Castle. So Dave, why don't I turn it over to you?
Oh, thanks, Lee. Great introduction. My name is Dave Castle. I'm the Executive Director of Care Equality. I'm wearing a couple of hats potentially on this call. I'm obviously, first and foremost, we have my role with Care Equality. Care Equality itself, not to get into some of the contract details, but as a subrecipient of the Sequoia Project's RCE cooperative agreement with ONC. So I'll be able to speak on behalf of the RCE efforts from that standpoint as well. But if you go ahead to the next slide, I just have a little bit of overview here. In my intro that Lee provided, you heard some of the statistics from our first year of operation in Cura Quality. Today you can see some of the current statistics over there on the right. There's pretty widespread penetration of exchange via Cura Quality nationwide. And what Cura Quality really aims to do is to build on the efforts of folks like Paul, who in the Commonwealth Alliance is one of our implementers, who have built up health IT networks that provide a lot of interoperability, a lot of data sharing, but for various reasons haven't been able to completely dominate the world on their own, and therefore need to work with others who provide similar services to other customers. And so what Cura Quality allows those folks to do is connect their networks to one another in a single standardized way. The mission is bears some similarities actually to the Trusted Exchange Framework and Common Agreement structure that I'm sure we'll talk about as the call goes along. We're in the experience that we have with Cura Quality, helping to inform the development of especially the QHIN technical framework, which, if you're not familiar with exactly what that means, hopefully we'll explain that further as we go along. But the technical standards that are used under the TEFCA ecosystem for exchange among the various organizations. Then you can proceed. We have Chuck?
I'm not sure, but I think we lost Lee. This is Carol. So maybe Chuck, if you would like to do your opening remarks.
Yeah, I'm here, Carol. So we're going to Chuck.
Okay, great.
I don't see Chuck's webcam view anymore.
Maybe that Chuck is lost.
Well, if Chuck may have lost connectivity, so why don't we then go to the next presenter, which is going to be John. Can we go over to John next?
Excellent. I'm online, Lee. I was just having
there you
trouble
are.
with my web.
All right, Chuck.
Okay. Thanks for inviting me. The issues that we face today are just a culmination of decades of inability to share data. Next slide, please. HL7 has been struggling to achieve the ultimate of seamless data interchange for nearly 30 years. Half of all data exchanged around the world goes on some HL7 network, and yet much of it still misses the ideal. Next slide, please. Uh, 10 years ago, we formed a Fresh Look task force which tried to identify some of the key hurdles to interoperability. What if we could start over and not throw out all of the work that had been done prior to that point? And FIRE emerged from that task force. I think one of the key milestones was when the JSON task force identified open APIs as the fundamental building block for health data exchange. And shortly thereafter, the Argonaut project was formed to augment that. I think the fact that the private sector was able to embrace it when Apple in January of 2018 announced that they had integrated FIRE within the operating system, and we could now share data across platforms and between health systems. And lastly, of course, when the final rule was published earlier this month that identified FHIR as the standard by which data would be exchanged. It was, to some people, came on the horizon rather abruptly, but it was a 10-year journey. Next slide, please. I have taken this slide from the ONC deck, which shows that the certification rule will require delivery of the planning for API enablement in a very few months. And we will go live with that about 20 months, 22 months from now. So we have a journey that will be very complex, and our opportunity is to smooth that for you. Next slide, please. Part of the success of FHIR has been not only as an open API, but also as a distinct platform. Next slide, please. One of the enablers to share data between health systems was when Smart on FHIR was created and enabled ISO standards for secure data exchange and for authentication. Next slide, please. One of the really important part of the FHIR stack is the clinical decision support enablement, which will be fundamental as we move forward in sharing external resources that can be brought to bear at the time of patient care, decision-making, and processing of large amounts of data. Next slide, please. In order to make this more effective, FHIR was originally envisioned as single peer-to-peer exchange of data between a patient and a provider or between two providers. But bulk data on FHIR allowed the exchange of hundreds of thousands of patient records in near real time, allowing for successful analytics that will prove really essential as we struggle with the evaluation of COVID-19 patients. Next slide, please. The FHIR Release 4 was just the beginning because when that was published in December, the process for developing FHIR Release 5 had already begun. And if we are able to keep on the timeline, we'll deliver that about 15 months from now. It will provide a host of other capabilities as well as backward compatibility. Next slide, please. Keep going, please. The FHIR Accelerator program began 2 years ago with the Argonaut project and then Da Vinci, which has been identified in the final rule through the CMS rulemaking process as the means by which data will be shared between payers and providers. The key to the success of this process will be the unprecedented relationship between a patient community, the physicians, and the payment systems. CMS has worked hand in glove with the other payers to make this a broad national program. Next slide, please. Next slide, please. there are two new fire accelerators that are about to emerge. One with the CDC, which for the last 2 years has been piloting a program with the capability of capturing real-time clinical data and feeding it to the CDC rather than the onerous task of spreadsheets being faxed to Atlanta once a month. Next slide. And the last of these, and perhaps the most exciting for many, is the Vulcan project, which is a public-private partnership for research, both regulated clinical research that the FDA requires and non-regulated research that comes from NIH, CTSA, and from other federal agencies. Next slide, please. The AMA, after 5 years of struggling with their clinical modeling initiatives, have finally come on board to enable a host of technical and data exchange approaches that will really fundamentally change the way physicians partner in this process. Next slide, please. Lastly, and I think most excitingly, the 6 large healthcare cloud vendors have agreed to use FHIR between systems and from their health system, both on a per-patient basis and bulk data on FHIR. Last slide, please. The future really lies in leveraging all of these technologies in a collaborative environment. Over the last 3 weeks, there's been unprecedented energy to partner with a host of other standards development organizations, EHR vendors, certainly the big tech vendors, and the new COVID-19 Healthcare Coalition that brings health systems and technology vendors into one space to accelerate addressing data for control of the pandemic. So thank you. Last slide is just how to get in touch with me. I'm a good email correspondent, so feel free to reach out. Thanks, Lee.
Thank you, Chuck, and I can tell you that he is very good at getting back to people. Chuck is really a great communicator. Really appreciate it. John, why don't we go over to you?
Thanks, Lee, and good afternoon, everyone. My name, again, is John Vancourt, Director of the Interoperability Division within the Office of Policy at the National Coordinator for Health Information Technology. And I don't have any slides today, but instead we'll just share with you the policy story as we've lived it with regard to interoperability. I've been working at ONC for about 8 years now and have had the pleasure of working very closely with almost all of the panel members here, or at least all of the panel members' organizations, on trying to advance the issue of interoperability. And we have made tremendous strides with regard to computerizing our nation's healthcare system, but as everyone knows, and as Lee outlined at the top of the call, those computers don't talk to each other as well as they need to. And so Congress recognized this and passed the 21st Century Cures Act in a overwhelmingly bipartisan fashion. This was a 95-5 vote. That type of bipartisan support is not seen all of the time here in Washington, D.C., but is a clear indicator of how important this issue was and how much support there is for the work that we at ONC are doing to address the problem. At ONC, we have the core priorities of addressing interoperability and reducing provider burden, and have numerous activities that we've been undertaking to support that. On the interoperability front, I'll talk a little bit about our rules that were just recently released and focus more on the Trust Exchange Framework and Common Agreement, which is the area where I am a subject matter expert. So the core message about the interoperability rule that was released from ONC is that it will give patients unprecedented, safe and secure access to their own health data. This is an incredibly exciting time to see the innovation that is going to be released because of the creation of application programming interfaces that will be able to be used without special effort and will allow for enormous innovation within our healthcare system. On the Trust Exchange Framework and Common Agreement side, we are working to create the common legal and technical requirements to allow for network-to-network data sharing. So right now, one of the problems that we face with our healthcare system is that there are pockets of interoperability, but it is not wide scale. And one of our goals with the Trust Exchange Framework and Common Agreement is to create a single on-ramp to nationwide interoperability. And we're working to see that information securely follows you where and when it is needed, and so that we can enable seamless and secure exchange of health data across networks for patients and their care teams. We are working very hard to get this right, and to do so, we have had numerous steps engaging with the public. We've had 2 drafts of the Trust Exchange Framework and Common Agreement. I think everyone on this panel's organization submitted comments, and we're very appreciative of that. We received comments from the public as well, and have adjusted our policies accordingly. We are currently working to adjust our policies following the release of the most recent iteration of the Trust Exchange Framework and Common Agreement. And we have, as Dave was mentioning, awarded a cooperative agreement with the Sequoia Project to have the Sequoia Project act as the recognized coordinating entity for TEFCA. And the RC's role is to develop, update, implement, and maintain the Common Agreement and the QHIN technical framework, which is the technical aspects of the Common Agreement. And we will talk more about the specifics associated with all of this work, but I want to make sure that I make clear at the top of the call that we really ask the community to get involved in the work that we're doing, and you can do that in numerous different ways, primarily through participating in the recognized coordinating entities' numerous activities to engage with the public. I invite you to visit their website, and Dave, correct me if I get it wrong, rce.sequoiaproject.org. And also, if you'd like information from ONC, we have healthit.gov/TEFCA. I should also mention the information resources that are available on our rule, which are on healthit.gov/cures rule. So with that, I am super excited for the conversation today. Thank you again to the Discover Alliance and everyone else for having me.
Thanks, John. And, I also want to echo, John, not only what ONC has been doing, but certainly Sequoia as well, Dave, Marianne Yeager, many, many people have been, you've really made it very open, very transparent, and really trying to engage in as many forums as possible industry participation and feedback. So I think everybody should be applauded for really the efforts there on the outreach. So thank you very much. All right, let's go over to Scott.
Well, hi, everyone. So I don't have slides either, like John. I thought I would share, though, a few thoughts. So the thing that I think that ties this group of people that you see on the screen together is we, frankly, predate the efforts mutually. We predate the efforts of the government to provide direction in this regard. So the kind of work that has already been done is actually pretty exciting. The attention of pretty much all of the organizations on stage is turning at this point to something that's more pressing. I think all of us realize that that the patient is why we're doing this, right? That we want health information to be exchanged in order to improve the health of patients. And nothing is more acute than a global pandemic when it comes to the need for health information to flow freely and without any encumbrance. So, so that I think is useful. So recently I kind of pondered on the question of what one does in an emergency, right? So if you're stuck at home, you don't try and figure out what you don't have. You go downstairs and try and figure out what you do have. What do you have in the cupboard? So the folks that you see on the screen represent a lot of work that's already been done and a lot of investments that represent value that can be utilized in this context. The challenge that we have with this pandemic really, of course, it's not limited to interoperability. I don't want to, claim that interoperability is the most important element. Certainly, personal protective equipment is very important, and testing is important. But interoperability is really important too. So, triage as the first step of an activity related to somebody who is perhaps ill is important to figure out where they go, and that implicates. Fundamentally implicates. Oops, time for a break. So fundamentally implicates query. So query, is I think in pretty good shape in the country in a lot of ways because of the work by three of the organizations that are on stage here. So that's exciting. There's a lot of things that can be queried. There's a lot of data that you can get a hold of. Then the question is, how do I then refer from where I am to where I need to go? That implicates push messaging of the sort that direct trust provides. So, that I think those two aspects of healthcare information exchange are both implicated by the needs of the COVID-19 epidemic. And the interest that we have in utilizing FHIR in the future notwithstanding, which we do all share the value proposition that we believe FHIR represents, what we have in place today is all we have. And we need to make changes in the next several weeks, not in the next several years, to solve problems that are being experienced in our marketplaces today. And the investments are not only in standards and in technologies, but in organizations that are deploying real-world exchange capabilities. Commonwealth and the members of SHEIC, as well as the care quality implementers and the direct trust operator organizations all represent assets in that regard. So just a little bit about my organization. I feel like it's important that we understand the assets we have. So let me give you a sense of what our asset represents. We're an organization with roughly 100 members, 40 of which operate a network which is a very, very large healthcare network. I'm not going to compare it in size to another network. I don't know how one compares networks really. But what it amounts to is amongst our members, they are supporting a very, very large number of healthcare organizations. At this point in time, we're talking about, I always get this number wrong, so I want to make sure I get it right, 238,000 organizations that are exchanging roughly 87 million transactions a month. So there's a lot of value in all of that already, but there are also some barriers that we need to we need to collaborate to surmount, and that's true for all of the things we currently have. But those barriers are not what I would call, they're not Jersey barriers or brick walls, or they're hay bales. I mean, they're like, let's just move this out of our way and get started. The biggest issue, and this is according to the ONC's, it's actually the AHA report that comes out that describes the barriers people see. The biggest issue with direct messaging is people can't find direct addresses. And the biggest problem with that is that people aren't publishing them. So making them publicly available is absolutely essential. It's a part of the rule. So today, at this point in time, I feel like we have an incentive which trumps the incentives that are a part of the rule, which is care. We want to improve care, and we have to improve care, not in months, not in years, but in weeks, and we need to take advantage of what we have. The great news is this set of organizations, we already collaborate. we intend to collaborate and continue to move the ball forward.
Thanks, Scott. I mean, I think some of the numbers that you go over on and how direct trust is really impacting and that protocol standard is really increasing the amount of data exchange is significant. It really fits in very, very well to the whole discussion we're having here around interoperability. So great stats, and again, thanks for your leadership there. Kelly, let's go over to you.
Great, thanks everyone. Thanks for having me. I feel like I should just say amen to so much of what Scott has said. You're right. I mean, many of us have been working on this for a long time, and I think I can attest even to John's personal commitment when I was still on the HIE side and the state side of things. We've worked on a lot of issues across this panel over more than the last decade. So I am excited to share a few ideas and some thoughts with you today. For those of you who don't know Chic, I have been with the organization for about 3 years. We are a national collaborative. We have about 130 plus members, about 80 of which are health information exchanges across the nation. We cover more than 90% of the U.S. population in our work, and we just completed an annual survey of our community, which was announced as part of the ONC annual meeting just the end of January. There's a link on our website if you guys would like to take a look at the details, but in general, you'll see that our community is nonprofit, community organizations, regional coverage, some state entities. There's a variety of ways to do health information exchange across the nation, and we have a little bit of everything within this community. But there is national coverage within our community, and I'm excited to work with so many folks across the nation. One of the things that we've identified in that annual survey is that our community works with a variety of social service organizations and other partners, probably to no surprise. The mission is very important to us. We are nonprofit organizations, and so working with community blood banks and food insecurity and housing insecurity and all of those things that unfortunately many of us are talking about right now with the COVID response and planning is very real. I just met with our CEOs yesterday and encouraged them just to remember that I sincerely believe we were made for such a time as this. It's a terrible thing to be going through, and I, even as a national healthcare leader, probably share many of the same uncertainties that all of you are going through and trying to process as well. But I've also seen this community working for those of our folks who are looking at sheltering in place or maybe looking at displaced populations and repurposing some existing infrastructure. We have one, for example, right now that has repurposed some existing state infrastructure to support testing locations. We have others who are working with Medicaid offices, working with their state Department of Health, working with CDC. Think about things such as registries and immunizations. I know we don't have that yet, but if we are anticipating planning going forward through the next few seasons or through the next few years even, health information exchange is going to be a really important component of that. So one of the things that we have been asking the communities to do, and this will be our focus going forward, is to create even a more robust network. As Scott said, many of us are already connected. We already partner on many efforts, but our desire is for providers to be connected before we're faced with these types of pandemics. I certainly hope we don't face one of these again, but just whenever we're going through hurricanes or earthquakes or fires, think about all of the West Coast fires that we've had. Those types of events are not going to go away, and health information exchange has really proven itself to be a key leader and support in that. I don't mean to submit to you that we're in the front lines delivering care like many of our godsend providers right now who are risking their lives out there at the moment, but our HIEs stand ready and willing, and we're trying to provide the infrastructure for folks around the COVID efforts. This is just one way that I think our community has stepped up and has helped in that. As far as the rules go, again, I think much of this would continue to happen. The rules are certainly an important piece, and we need that delicate balance, I think, between public and private efforts. And so Cures, I think, is moving us in the right direction. Certainly it's going to take continued conversation amongst our communities for everyone that you see here on the panel today. But I do appreciate that there is an open and transparent process. As a former regulator, we really do read the things that come in. We do read the letters that come in, the comments. It is important to comment and share your feedback and be thoughtful about that. And so when a regulatory body provides you with templates and specific questions, answer those. They're trying to point us into the most helpful ways to provide responses and get our own communities on board. So I'm excited to be part of the panel today. I'm excited to move the work forward. I can only hope that I have some impact as a national leader on the virus that we're facing right now. And I certainly stand ready if anyone has ideas or opportunities or ways for us to get more involved or share any further insight. So, Lee, thanks for having me.
Thanks, Kelly. Some great comments there, and how Chic is playing a role. Paul, let's talk about the Commonwealth Alliance.
Great, thank you very much. So, been here about 4.5 months or so, but fairly long experience in health IT and interoperability for a long time. Thanks to Dave for giving us the shout out there. Yeah, I guess if we hooked everybody up, the problem is solved to some extent. But the fact is, we need consumer choice and we need business choice as well for the way we get services. So when I look at the way Commonwealth does things, we have members. The members are vendors in this case. Kelly's members will be quite different. They'll be state HIEs, regional HIEs. We're all looking to solve the same problem using different building blocks, a different set of Legos. And when I think about the way TEFCA is set up, and what we're really here to talk about kind of how the new rules impact stuff, a couple things pop out. John mentioned a single on-ramp, and I look at it a little differently as a single interstate system, and we're all on-ramps, right? So we need the chic on-ramps and how they work to be able to interoperate the on-ramps to start at the rural, state, and major on and off exits off the various turnpikes, parkways, and systems we have out there. We need the rules to be harmonized such that no individual on-ramp is better or worse than another from a certain minimum perspective, right? We want to make sure that I can enter one and get data across the country as easily as possible as a provider. Then we look at the information blocking, and yeah, it has some provider stuff in there and information blocking, but really now we see the focus on the patient. Right? Patients have access to data. There's a standard set for working on that. And this changes the default flag to yes versus no. Right? It's not that, and a lot of practices don't even know that this is the case, right? I hope that everyone, as they try and solve these problems, tries to be a patient first, right? And try this out for yourself. Go to your practice, ask for your records, and watch what happens. And sometimes it's very easy, sometimes too easy, right? You go, wait, that's not right. You're supposed to do a fair amount of ID proofing before you hand me that username and password, and I haven't even said giving you a driver's license yet, and I don't know you for boo. So what are you doing giving me a password? There are times it's very, very difficult where they send you through a token and go home, and you go down to 7 levels of human resource records, people. You get to the bottom floor, you make a right, and you find a person that finally says, here's how you get on the patient portal. They send you home, and then your ID proofing doesn't work, right? We probably all experienced this, right? So, but the moral is, with all those challenges, which I think Scott said it well, there's a lot of assets on this screen here, and we're not the assets, by the way. It's the things we do behind us. The shepherd of this organization, and the Alliance is doing great things, whether I exist or not. I just poke it and prod it once in a while to make it a little better. But we're changing the default position to on. And I think with patient access in particular, that default was not always the case. And again, I caution, it's not vendor's fault all the time. It's not provider practice fault all the time. It's the fact that healthcare is in many ways set up for data exchange as one fly in the ointment shuts down everything. You really only need one point to say no, and the transaction stops. And that could be a policy, it could be a person, it could be a practice, it could be a vendor, it could be a system and a network. And this says all you need to now turn to on and now execute the exemptions when necessary, which is a reverse attitude on the way to share data. So as Common, we're thrilled to see the rules drop, and watching all the activity, I can say that what we saw was a lot of requests in for how can you help. There's a lot of people asking where the alignments between one rule and the next rule. Can I get exemptions here versus doing that? Can I just join a network and solve some problems? Alerts and notifications is the primary there. But we stand at the ready to help as much as possible, and it's definitely the objective of many people on my board and members of my alliance that we are the absolute first QHIN under TEFCA. So the race is on, everybody. Looking forward to the contest and being first. We're in this for the long haul. So thank you very much for having us, and I look forward to the Q&A in particular.
Great. Thanks, Paul. Appreciate it. Some great perspectives, and hopefully for all of you, the audience, all of these people that are on the panel, representing organizations that are key players in relation to not only interoperability, but as you've heard from everybody, we're all, quote, veterans, I would say, as part of this. And as part of that, we have really a very strong, I think, relationship between all of us to work together for the common good and working with all of you as well. Carol, why don't we put up the first polling question, if we could. Right. And again, while that polling question is coming up, and it's, have you read the executive summary of the final rules? So you'll see, I believe, down on your panel, the ability to just click in either yes or no, and we'll calculate that in a second. Obviously, there's a lot of good information, summaries, and other data that's been put out regarding the final rules, and I've been very pleased in seeing a lot of the great work that has come out and summaries that have been put together, as well as reading the entire document. There's a lot of good information there.
Yeah. Sort of interesting. Yeah. Go ahead.
How are we doing, Carol?
Yeah. I'm about to close the poll out. Pretty interesting that the majority have read the executive summary.
Great. 68%, 70%. Terrific. Great.
Yeah,
Thank you. Okay. With that, we're going to go into the Q&A. And so first, before I start the Q&A with the panel, again, if you have any questions that based upon what you've heard, or any burning questions that you've got, please don't hesitate to key them in for us, and we'll try to get to as many as we possibly can. The first question I'm going to ask the entire panel has to do with COVID-19. And with the sudden focus of attention on COVID-19, what can the healthcare ecosystem do right now to solve the interoperability problems unique to this pandemic, and how will the industry change in the future when the final rules and TEFCA are implemented in 2+ years? So that's kind of the question there. John, you mind if I start with you first and see what your thoughts are? Obviously we've got the rules out now. People are looking to kind of move forward. We've got the common agreement that's in the process of being developed this year. We've got a lot of pieces in play. So given the pandemic and today and what we've got for interoperability, what are your thoughts on where this is today and how are we affecting COVID-19, and with interoperability hopefully and the digital highway being implemented in the next couple of years, how will that change?
Yeah, Lee, I will take that. And I think the first point to think about is how do we work to support those folks who are on the front lines, who are engaging with the patients that they are caring for, and they are doing tremendous work, looking ahead, thinking about what needs to happen. And one of the things that we're doing at ONC is helping connect them with who the right resources are and how that can facilitate their work. So if I did want to make this point, which is if folks do need support, they can by all means ping me, but also there are numerous websites that provide resources that are supportive and helpful. I wanted to make sure folks are obviously aware of the CDC's website, but we at ONC have put up a couple resources that are supportive of our folks in this area, or our, those folks who are in this area. And that includes a dedicated page on healthit.gov/coronavirus with links to various resources. And then also there's a new page that we just launched on the Interoperability Standards Advisory associated with the new COVID standards. So want to make sure folks are aware of at least that, but let them also know that one of our responsibilities as ONC is to be the coordinator. So we're helping connect resources between different agencies, getting folks out in the field resources or connected into our sister agencies. If there's a, for example, a question that comes in about CMS payment policy or something, we help funnel that around as we have very good connections throughout the government. And so we're also connecting industry partners with each other and with those folks in the government as appropriate. So that would include also helping funnel questions and points to folks on this panel too, where appropriate. So eager to hear from other panelists on the same topic.
Great, John. Other points of view on this?
Yeah, this is Chuck. We are involved in at least a half dozen initiatives. They need to be funneled through ONC or some single source so they can be better coordinated. Most of them have dedicated individuals who are really struggling to create solutions for interoperable data exchange, and they're doing so in a vacuum. And we really need to bring them together so that we can enable more effective use of their skills and time.
Great, thanks, Chuck. Scott, any thoughts from your perspective?
Yeah, and I agree that there's a need for some coordination here. I think the panelists on the stage, are already coordinated at some level, communicating, I think, directly. I think the COVID-19 Healthcare Alliance that launched yesterday sounds like an important part of this as well. We look to actively interoperate with the HIEs, with Care, Quality, and Commonwealth to try and figure out how our current capabilities can be utilized to solve some of the kind of problems I was laying out before. To me, there are many of the specific use cases which we can actually enable good, solid communications for today with relatively little coordination, but some coordination is required. In particular, what's important to me is that a healthcare organization that wants to receive referrals by a certain door tells people what that door is. And so from my perspective, that's the direct address of that door. Today, it is frequently not known for certain what direct address needs to be the place where you would direct such a message. And when you're talking about referrals of the sort we described, that's the place that implicates direct messaging and really needs, again, the removal of some hay bales, which is really not even the creation of new addresses, but just the designation of the address that people want to receive referrals at. So that would be, that's something we're actively looking to be able to enable in our directory, to tag those addresses so that people look up in the directory and they can find out where a referral is to be sent. So we're actively working on that. But we need to collaborate with other organizations to do that, the HR community, the HIE community, and others. So that's, to me, it's one of the things that I would like to just put in a little plug for the Discover Alliance. The opportunity to have a single clearinghouse for information from this community would be very useful. Right now, there isn't a single clearinghouse for that. We have to make individual collaborative connections. That is, I think, an area in which there's a gap.
I agree. It's a great opportunity, I think, to leverage Discover Alliance for that collaboration. Hey, Kelly, one other, I thought we'd go to you as well. The HIEs are playing a very active role in a lot of the data exchange that's going on here. Any thoughts on my question as well, as far as, kind of how they're playing today and in the future, how this is going to evolve in the future?
Yeah. And specific to your question, what can we do now? It's much of what we have asked folks to consider in the past whenever we're facing such a natural event occurring, and that is to get connected, get provisioned, get credentialed, be partnered up with your colleagues now. Don't wait until we're faced with an emergency. But again, right at this moment, I would consider getting connected. I would reach out to my partners. Much of what Scott has said in terms of providers, your community health centers. There's been a lot of discussion about prison health care, correctional health care. Think about that information carried from folks moving in and out of that population and where they go within the communities to get support for their health care. Schools right now in many states are not in. I hope in most states they're not in. I know in my home state that we're not, certainly for several more weeks. Think about talking with partners in school nursing and education and your local colleges. All of those impact the existing structure as well. The other thing that I would say is be part of your community's emergency preparedness plan. These all sound like some simple things, but whenever you're really pressed, I think having those existing relationships help. And to the second part of your question around how do the rules impact this and what does this look like going forward, in my ideal world where we are interoperable and supporting patients, there certainly is a level of patient engagement and partnerships that are already existing. And so Medicaid's already connected. Your fees are already established. These partnerships are already in place. Your EMS services know who you are. You know who your fire chief is. All of those sorts of basic partnerships and relationships make a difference. And I think that's why we've seen these community organizations really be able to ramp up quickly to respond because they do already have those relationships. So those are my thoughts in terms of immediate need and what the future looks like and what the rules will pay for us. I think it will enhance what we do currently do, and there will be much more to realize because the patient will not let us do otherwise. The patients will demand for better care and better systems to be in place. Absolutely. So that's my thought. Thanks.
And Lee, this is Dave. I think if I can build on that a little bit, I would agree with what Kelly is saying, and harken back to what Scott said as well, that when you need to do something in a matter of days and weeks, you go down into the basement and you see what's in the cupboard, and even if it's a little dusty, you dust it off and you use it. And in this case, I don't think anything is actually dusty, but if some things are, we'll use them anyway, because that's what we've got. On the care quality side, with respect to what Kelly was saying about get connected now, we've tried to take some steps to make that a little bit easier for the networks that participate in care quality to do. We, under normal circumstances, have a requirements that I think make sense and are understandable, that if you're getting information, you also provide information, so that we can roll out more quickly to a lot of users, even if temporarily, for the duration of the emergency. We're waiving some aspects of that requirement, just to make sure that if anybody can find any way, whether it's a simple app, a portal that somebody provides, even if you can't share information back, if you can tap into the very widespread care quality ecosystem to get access to those treatment records, that's hugely important.
Great. Thanks, Dave.
I was actually going to mention your work there, Dave, because I think it's that simple policy change, I think, was a massive important change to make, right? It's not on the shelf. It's sitting there in your face going, here's my assets, what can I do with it? I did want to point out one thing just because I feel like it's, I think we all did have assets working in place. I think we all went to our service providers, information technology vendors, everybody and said, are we hardened and are we ready? And we all did that. In fact, we made a data center move in the middle of this just to make sure that on the other side, if volume goes up, we're good to go. We actually had it planned already. Most of our vendors were now going, wait a second, an outage in the middle of this doesn't seem like a good idea. I said, well, I also want to find out that volume triples next week and the exact problem we're trying to solve for when we planned this in the first place doesn't get resolved. So we went forward. But there is one angle that I think we're all struggling with a little bit. I know Dave, Care Quality, and Commonwealth both are, is we have national networks that go across state boundaries. We're inherently federal. And there's a fair amount of other use cases that are usually more bounded in a state purpose, and that's public health. We are having trouble figuring out and coordinating what authority under which to try and help someone do aggregate population health analysis. We hear in the news the data we heard from China was different than what we experienced here, right? We've heard that the 20 to 50 somethings tend to be either asymptomatic or very low symptoms, and we should worry about the older population. And almost every broadcast you see right now has someone 26 to 36 years old saying how hard the disease hit them, right? Almost like a public service announcement to say, time out, be careful, it might be different than what we were told. And then we're also hearing things like pre-existing conditions, things related to, lung capacity, whatever, asthma, COPD, all these things may be contraindications and to be more careful. But the fact is we don't have that data at scale. We're going on, fortunately we weren't first, right? So we knew something was coming. It's kind of a hurricane, not an instantaneous tornado. But we got data from that. Some of it's not quite right? So we don't really have a good way to pressure test that with the data we have. We have 200,000, 300,000 tests done, 40, 50,000 people tested positive. You would think we have a way to get that end together and say, what are the patterns and trends that allow us to do utilization, therapy planning, all the like. And actually, it's very hard. In fact, we're finding it nearly impossible without an executive order basically telling us we have to do it. Because the data, it's important. Security and privacy still trumps a lot of the stuff we're trying to do. We don't want to give the data into a database that doesn't have the proper protections, data security, et cetera. So while we're seeing fantastic exchange on provider to provider, we're seeing great acceleration of patient portal access too. People are interested in their data now. Everybody's interested in the data. But there is that one use case that we're having significant trouble servicing. And I think early versions of TEFCA, which had population health queries, I think is one that is probably likely to become revisited at some point. Does someone ask, how do we do that and how do we attach public health? I expect it to iterate over time, but I hope we don't lose the opportunity to remember what we couldn't do for what we should do next.
Good
Lee,
comment.
I
Thank you.
have another
Yes.
issue that I'd like to raise, and that is we're struggling with capturing the data. We hadn't clearly defined in our existing electronic health records what these data actually meant and how to capture them in a structured way. And so people are scurrying about trying to identify them. Now, Link has provided a lot of the codes, but in terms of the clinical encounter, we don't have the concepts. And I can tell you there are at least 2 projects right now that are hurrying their development in creating those. And we need other people on board to lend their technical and clinical expertise.
Okay, good. Thanks, Chuck.
Yeah, Lee, I'd
have...
like to jump in as well and just make one additional point that I wanted to make sure
Sure,
everybody was aware of. Yeah, that our Health IT Advisory Committee has been taking on the topic of what else could we be doing as far as the federal government related to the COVID response, and has been working in rapid fashion on this topic. There will be a public call of the advisory committee tomorrow, and if folks would like to join that, I really encourage them. I'll put a link in and maybe we can share it via the chat with folks.
Certainly can. Great. Thanks, John. Carol, do we have any questions? I'm not seeing any here, but do we have any at this point that you're seeing?
Oh, yes, of course we do. I'm going to just jump in here for a second. One interesting question right away was, and it's a question I think a lot of people have, is when the rules will be published in the Federal Register.
John, that's probably for you. Do you have any idea when the rules are going to be, or expect to be published in the Federal Register at this point?
Yeah, I don't have an answer for that. Sorry.
Okay, no worries.
Okay.
I think we need a roulette. We need a roulette wheel, and we'll spin it, and we can all answer it as well as John at this point.
Everybody pick a month and put $5 in, and we'll see who gets it right.
Right.
Yeah. Just like the roulette wheel we all had when we were saying, hey, when are these rules going to be out? Everybody was saying, well, gee, I think it's going to be next week. No. But, hey, John, we understand. It is what it is. So unfortunately, there's no answer for that one at this point. I guess with everything going on, it's probably affecting when publishing, et cetera, as well.
Right. Do you anticipate any TEFCA participation issues as the blocking exception goes forward?
So the question is, do you see any TEFCA issues as the blocking rule goes forward? I guess, Dave, that would probably be to you.
I certainly don't think that you will be more likely to be implicated in information blocking if you participate in exchange activities under the TEFCA. I would find that difficult to believe. We'll certainly take a look at any policies, and I'm sure John, you would agree with this. I mean, we'll make sure that none of the terms would implicate information blocking, and we'll be careful about that in any operating policies and procedures. But I don't think that you will be bringing yourself information blocking issues by participating. Hopefully, rather the opposite.
Yeah, I want to make clear on that last point there that there is not an exception within the rule for participation in TEFCA. So there was a request for information on that topic in the proposed rule, and is a potential thing that could be considered in the future, but it is not one of the exceptions under information blocking. But I thought Dave did a good job of touching on the point that the multiple considerations that go into a fact-based analysis of whether or not one is information blocking. I really encourage folks to learn about those different considerations. I won't go into all the specifics here, but healthit.gov/cures rule, we have fact sheets that describe these different aspects of the rule, and encourage folks to become familiar with those.
Let me ask one other follow-up to both of you on that. One question I'm sure a lot of people are asking, well, how do I get involved in the TEFCA, as the common agreement is moving forward? What are the types of venues that are available for participants to get involved, to influence, to have their voice heard as part of the process? Could both of you take a moment to talk about where people should be looking to get involved?
Sure, and I can go first, and then John can correct me on anything that I get wrong, which is our typical approach on these sorts of things.
Doesn't happen often.
You can go to that website actually that John mentioned, rce.sequoiaproject.org, has the upcoming public webinars, stakeholder feedback sessions on it that are open to the public. There will also be as the first draft of the common agreement comes out. So what's been released by ONC so far has been 2 drafts of the minimum required terms and conditions. So the core policy terms that ONC has identified as needing to go into that ultimate legal structure that underlies the TEFCA. The final common agreements that would be signed by QHINs and ultimately govern exchange activities needs a variety of other provisions in there, ranging from what what I will call standard legal boilerplates, which is nonetheless important to other pieces that just aren't necessarily core to the policy, but are certainly important to any executable agreement. So the first draft of that actual combined agreement will also be available for public comment here at some point as we go forward in the future, as will that QHIN technical framework that I referenced earlier and that John elaborated on. That is not part of the contract itself, but is referenced by it and lays out the actual technical tools that would be used to accomplish the exchange goals that are put forward in the common agreement.
Okay. John, anything further?
Nothing to add. Just I just put in the chat that I'm sure will be then passed to the whole audience a couple different links, and including the one Dave and I were just saying, rce.sequoiaproject.org. We have established this public-private partnership with the Sequoia Project because of their expertise in this area, their experience in bringing together stakeholders to work to bridge different viewpoints and get to a ultimately successful place where interoperability is occurring. And so really do want to encourage folks to visit that. There's a way to sign up to get updates. I then also shared the ONC informational website, and then I just shared another link, which is where you can sign up for email updates. So we as ONC put out a email update each week, which provides various different resources that come out. So and then also my email address is in there for, if there are things that are appropriate for us as ONC to consider, please do reach out.
Okay, great. Carol, let's go back to you for other questions.
All righty. So the Cures Act mentions much about interoperability and the goal of smartphone access, but little is mentioned about the practical aspect of a patient accessing PHI via smartphone. How should providers interpret this?
I think it has to do the questions having to do with kind of smartphone with cures and kind of impact and how should, I think the question is around how should people that are using smartphones interpret some of the rule. Carol, is that what that is?
That's correct, right?
Okay.
How
John,
that could be regulated.
Okay. John, any thought on that, on smartphones and how they're impacted as far as the rule from your perspective?
Yeah, I'll make the general points that I think are really important, that, the Cures rule is going to give unprecedented access to patients' health data, and this is going to allow for them to view that data on their phone, and using things like the OAuth 2 workflow, be able to get access to their information using a credential that they have so it's safe and secure. And so there are certainly the privacy considerations that are talked about and are part of the rule, but patient choice is really paramount here, that they should be able to gain access to their data, and that choice should not be taken away under the guise of protecting privacy. So there is certainly the ability to have providers share information about the apps that the patients are connecting into that they're using. But again, the rule is about getting patients access to their data and giving them choice.
So I just want to make a comment about, and I agree actually with you, John, and actually with a bunch of folks who've commented that it's a false dichotomy to ask the question whether you need security or access. It's so when they say it's a false dichotomy, it doesn't mean that you need to ignore security in order to achieve access. It means that you actually need both. And so I think for the scale of what it is they're already planning in the rule, the approach is actually secure as far as it goes. The question then relates to things outside the purview of HHS, and a lot of people pointed this out, is that once the data is freed from the shackles of HIPAA, so it's been downloaded by the patient into their app, what happens then, and who's in charge of that? And that the challenge for us as a society is, as we encounter things like the COVID activity, people are going to have this overwhelming sense that the access to data trumps privacy. And I think that we really need to be careful not to throw that baby out with the bathwater. Our interoperable exchange mechanisms today start with privacy. They are fundamentally private and secure as a mechanism that is underlying them. So if we build new things that don't have those capabilities, we need to be conscious of that. And I think that the good news is that there is consciousness about this. The bad news is that it isn't really up to the ONC to regulate that territory. It's outside of their purview. So once we get out there, we do have a question to be wrestled with. What happens after the data is released from HIPAA? And so there is I think, a fundamental question about what happens when an app gets a hold of your data, and what sort of rights do they have, and what little EULA did you click through that says that they can send it wherever they like? These are fundamental questions. They're not, they frankly don't belong in the rule. They might belong in Senator Gillibrand's new legislation on data privacy or somewhere else, but they don't, it's not the ONC's fault that they didn't regulate data once it had been freed from the shackles of HIPAA.
Okay. Any other perspectives on the panel?
The one thing I would add is, just one quick thing, is the other thing the information blocking rule does have in it relative to this is you can raise the bar if you want to on security and privacy, but you just can't do it to the point that it makes other people's ability to get data more difficult than it is for yourself to get data, right? And I think that kind of helps equilibrate things a little bit. So if you want to raise the security bar a bit, then when you, as whatever vendor technology you're creating or provider, want to now go get data from someone else, you got to be stuck with the same level and bar. So it kind of a forcing function to say, be reasonable. Yes, high security, the things that you would expect, but you can't block it by saying this other guy has to be up here. So that allows that consumer choice to say, we are not going to release it at a bar that's lower than what we would expect. Therefore, my release is probably secure. It is up to the person, as Scott mentioned right now, to do a little bit of homework to make sure the apps they're using and reading the EULA. The one thing that I would say that probably could use a national effort is more education on what healthcare data really is and why we protect it so strongly. And I don't think the average person knows, how dangerous it is in the hands of the wrong actor for their healthcare data in terms of stealing identity. It's not about your healthcare data. First of all, everybody should understand that. It's not about your healthcare data. It's what it gets access to past your healthcare data. Healthcare data is very good for resurrecting financial identities and draining your bank account. That's what you're really worried about. You're worried to some extent about your insurance plan being used, kind of, but as we change the way insurance is covered, that becomes less and less of an issue. So it's important to understand why we're doing it. I think a national campaign describing this would be helpful. My mother doesn't know anything about healthcare data, but very well knows the difference between a debit card and a credit card, and why we'd use one over the other for different types of transactions. Which one's more secure, which one you can claw back if something goes wrong and the number is stolen, which one is actually much harder to do. And you make choices based upon the knowledge you have and the assets you have. So I think we could do more to educate on a grander scale to explain, here's why you want to carefully pick those apps and not download every free app you find in the App Store, whatever phone you have, and giving it to all of them.
Good point, but I'll bet your mother knows who to go to for any questions about healthcare data now.
Well, yeah, I guess so.
Hey, Lee,
go to one site, one person, me, and it was always, if there was a problem with the system, it was my fault, believe me. Anyway, Carol, any other? We got probably time for one more question.
Hey, Lee, quickly before we switch, I did want to respond to a couple points that were brought up there, just to share some resources and make sure people are clear on something. So app developers could be subject to FTC sanctions for unfair and deceptive trade practices, as well as state law actions. So I want to make sure folks are aware of that. Also, Paul, I think great points. We do have a information resource. It's called our Consumer Guide to Data Access, and I'll send a link around to it. Colloquially, we call it our Get It, Check It, Use It website, which I think is super useful and would be a great thing for if everybody here could tweet it and share, so if people start to learn about, that they can get access and also the various considerations that they should be aware of.
Why don't we go to each of you? We're going to switch in a moment. We're going to do one more polling question before we switch over to Jenna and Vince. So let me ask each of you to take 15 seconds with any key points that you want to leave the audience with from that they should be thinking about as far as the new rules, TEFCA, as far as interoperability and where we're going. And let me start, Chuck, with you. How's that?
Sure. I think from our perspective, there are clearly defined timelines. Many health systems have dragged their feet and now are surprised and pushing back. And I think that resources have to be brought to bear if these dates and very strict timelines are to be met. And we can provide the guidance on that if you reach out to us.
That's great. And Chuck, I want to applaud HL7 and your entire group for tremendous work that all of you have been doing on that. So thank you very much. Kelly, let's go to you.
I think I'll repeat something that I already said, which was I genuinely believe we were created for a time such as this pandemic, the rules that we're facing. I think it is precisely why we each get up and do what we do every day. And we've made a lot of pretty incredible strides. I've seen that in response to this epidemic and other natural events. There will be more to come. And I am 100% confident that if we don't figure it out, our patients will be asking us for that. I think they already have. So I am excited. I am optimistic. We still have a lot to work through. If you have not looked at the rules, I would encourage you to start there. If you don't want to read all thousands of pages of them, there are some great executive summaries and materials out there. Take advantage of those and reach out to us as leaders to try to support you as you navigate what's been proposed before us. And respond, participate, comment, engage, and be thoughtful. Thanks.
Thanks, Kelly. Scott.
Yeah, I mean, I'll echo everything Kelly said. I agree that this is a time for us to demonstrate what we can do and to pull together as much as we can. I think it's very important to not lose sight of what we have the ability to do today. Now, that said, I think the future really is bright, but the future is also going to depend on us building on the rule, as the rule is a foundation. It's not meant to be a ceiling, it's meant to be a floor. And so there's an awful lot above the rule and beyond the rule we need to think about. The rule, I think, does a great job with patient, with patient's right to access and a mechanism to get that. I think when it comes to making data available from provider to provider, there's substantial work yet to be done, and that is not as fleshed out in the rule as other things. So we're going to need to work hard on bringing that bar way up because the providers really need to be able to get data from each other.
Okay, thanks, Scott. Dave?
Sure. Excuse me. So, as the next weeks and months go by, I would encourage you, as we already talked about, on the developments around the TEFCA elements under the Trusted Exchange Framework and Common Agreement. Please do provide us with feedback, respond, give public comments, look on the website and give us feedback there. In the more immediate term, I'm probably not the only one who finds it hard to focus on the rules in the midst of the ongoing pandemic. And there are a lot of irons in the fire. There's a lot of things going on, and I would agree that there's some coordination may be helpful, but at the same time, I don't want us to limit the creative things that people are doing. So if you're out there doing creative things, don't stop. Don't ask for permission necessarily, unless you need legal permission. But generally speaking, move forward. Try to do interesting things. And the only thing that I would say is, as you're doing those creative things, try to think as much as possible, without getting in the way of the immediate deliverable, of how those things can be standardized, generalized, and rolled rolled into the ongoing future interoperability framework.
Thanks, Dave. Paul?
Yeah, well, I hinted at it before, and I guess it depends which audience you're looking at as to what advice you give, right? If you're a provider and you're worried about it, start using your own systems, right? I think start looking at what the capabilities you have. Maybe you'll feel better when you realize there was this care quality connection or Commonwealth or some other thing that worked, and you did have a direct email address and you were able to email another provider and do some referral stuff that, quite frankly, you weren't quite aware of. I'm still amazed at how many providers I have that still hand me a paper script to go get a pharmacy fill. And it's like, I thought we got past that, and I had to walk on 6 blocks down the street the other day to get it to my pharmacy because they didn't know how to do an electronic prescription. So we know there's still work to do wherever we go. And part of it's looking at the tools you have. Look at the EHR and ask them where this stuff is and where you fit. Try and get access to your patient portals, right? And see how it works, and be responsive to those of us who ask for our data, because some of it doesn't work the way you think it works. It turns out that IT departments haven't done everything you think they're supposed to do for your practice, not by intention, not by design, often by accident, just missing a piece of a manual they need to do. And I would echo Dave's statement there that keep plowing forward, trying new things, keeping focus on what we do, and make sure that we as a collective on this screen, everybody would have been on a panel together in front of everybody in person if we could, thinks about how to leverage each other and make sure that, we're not in this as sole entities, nor is anybody out there to get anybody in trouble, right? The objective is providing better patient care, bending the quality cost curve, achieving the quadruple aim, right? It's the general goal is the same, and the belief is that, accidental or intentional data blocking, we just need to remove the barriers. So we're excited to move forward, and I hope everybody else is as well.
Thanks, Paul. John?
Yeah, I want to start with, I actually forgot to make the official disclaimer, which is that nothing that I had shared should be considered official guidance, and that the rule is the official policy. So please do read it. Please do consider our various information resources that I was telling you about earlier. And then I wanted to really second the comments Kelly was making and Dave was talking about, like, of sharing your thoughts, commenting through our processes. If there are things that are happening that folks are concerned about, we have a healthit.gov/feedback form where folks can submit topics, questions, challenges with interoperability that they're facing. Please do be involved in the Trusted Exchange Framework and Common Agreement activities. We have numerous ways to get involved. We really do want to get this right, and we do that in collaboration with our public stakeholders. So thank you for all of you who have commented, who have been involved. Thank you to all the panel members, Lee, Discover Alliance. Really appreciate the opportunity to be on the panel today and to talk about these really important topics. Thank you.
Thank you, John. Appreciate it. All right, let's switch and go over to Ginny Yost and Vince Albanese for the next few minutes to talk about Discover Alliance and give you an overview on iNavigator. Jenna, why don't I turn it over to you?
Great. Thank you, Lee. Are you able to hear me okay?
Yep, we can hear you fine.
Super. Okay. So before jumping into the Discover Alliance overview, I obviously first want to thank our most esteemed panel. So thanks to each of you for your time. Thank you for your insight. Thank you for your thought leadership. But most importantly, thank you for your dogged determination to achieve interoperability. I also want to thank our sponsors. Again, that's Cerner's and Healthcare IT and EFACT. We truly appreciate your support. And finally, a sincere thank you to Answers Media, to Dave Anderson at Anderson Interactive, and obviously to Lee Barrett at ENAC for the countless hours that all of you have invested into ensuring that this event was a huge success. So thank you very much. So you've heard Discover Alliance mentioned a few times, and I've got to think by now people are wondering, so who exactly is Discover Alliance? So just to give a little bit of background here, Discover Alliance is actually the resurrection of a project that was launched by Open Health Tools about a decade ago. So the project was originally named OLLI, the Open Library of Health Information Exchange. And at the time, we worked with state HIEs to share assets, best practices, lessons learned, etc., so that they could then stop reinventing the wheel. But as with many projects, the funding dried up. There was not a sustainability model attached to it. There was not a business model wrapped around it. And I think we all know how that story ends. So fast forward, though, about 8 years. And it was about 2 years ago that Mark Jacobs in Delaware at the Delaware Health Information Network, he reached out and he said, you know, Jenna, with the launch of Draft TEFCA, we need to revisit that work. But we really need to expand this to include not just the HIEs, but all of the different industry segments that are contributing to interoperability. And our biggest challenges are not going to be solved by one company or one industry segment alone. So when you think about a problem, you know, like prior authorization, if we're going to solve a problem like this, it's going to require the input, the commitment, the collaboration across industry segments. We've got to include the payers, we need to include the medical societies, the providers, the HIEs, et cetera, et cetera. So at Discover Alliance, we feel like many of the tools that are needed to solve these problems are available, but they're not discoverable. So people need to know where to go to find the use cases, to find the case studies, the APIs, the service catalogs, et cetera. Right now, we're kind of left with a Google search. So what if we want more than a Google search? What if we want to understand, you know, what is the role of the HIE in battling COVID-19? What if we want to see, you know, is there a mobile app that allows for HIPAA-compliant texting between the care team and the patient? We feel like we need more than a Google search. So, anyway, Discover Alliance was launched to create communities for collaborative problem solving, allowing for the discovery of information through the use of a living laboratory and a living library. The living library that I've mentioned is actually our iNavigator platform. So Vince, if you want to go to the next slide. So Discover Alliance serves as a broker of communities that connect people, processes, and technology. And again, so much is the foundation of what we're doing here. We think the biggest challenges facing this industry need to be met with a combination of people, processes, and technology across industry segments. Next slide, Vince. Okay, so we launched the organization. Actually, it was 1 year ago this week, so happy birthday to us. And we have been very fortunate to pull together a board of directors of some of the industry's leading experts in their field. So I just wanted to display our board of directors so everyone can be in shock and awe. But so our chairman of the board, Mark Jacobs, he's the CIO for DEN. The vice chair, Vince Albany, is CEO for Haven Health Solutions. The treasurer, Michelle Broff, the lead interoperability strategist with Cerner. Our treasurer is, our secretary is Scott Suey, the CEO for Direct Trust. Lee Barrett, president and CEO for ENAC. Joe Fisney, associate CIO for Geisinger. Brian Heffron, managing partner for Calibrated Health. Kelly Thompson, the CEO for Chic, and myself. So let's move on to the next slide. So, yeah, there we go. So this slide, it really just provides a graphic representation of what I've already referenced regarding the different domains of health IT, how we need to be working together, we need to be crossing these borders, crossing these boundaries, and we need to work together across these industry segments to solve our biggest industry challenges. We need to stop duplicating the work of others and instead leverage that great work that has already been done. Okay. So previously, you heard me mention a living library, and that's obviously a term you get when a bunch of non-marketing people get into a room together and try to name something. Since then, we have had some marketing folks get involved, and it's now named the iNavigator. But so leveraging though this library concept, imagine walking into a library that's full of books, tens of thousands of books, and you're looking for very specific information about something. But if there's not a card catalog, the library is useless to you. It doesn't matter how much information is available or how valuable that information is. If you're not able to find it, it is useless. So the card catalog provides the pointer to the information that you need. It doesn't store the information, it is simply the pointer. The Discover Alliance iNavigator platform is just that. It provides the pointer to all of the great information in other libraries and service catalogs and product catalogs that already exist. So just to hit on a couple of bullets, so within iNavigator, each organization can have their own card in the card catalog. The card in the iNavigator platform, though, it can contain whatever information you think is important to share. It might be use cases, it might be a service catalog, products, case studies, APIs, but it tells the user where to go to get information about that topic. It might be your website, it might be one of your PDF documents, it could be a marketing document, anything like that. Okay, so we want to be the single authoritative card catalog that points to the institutional library of health IT information, assets, services, and use cases. As the card catalog, we hold no content, but we do point to the documentation that is owned by everyone who participates in interoperability. But just a couple of final points. We do feel strongly this platform should not be owned by a for-profit company. The Discover Alliance was launched as a nonprofit membership alliance, and the source code was donated to Discover Alliance by Haven Health, so it is owned by the membership. And again, the final and most important point here is just that collaboration needs to occur across industry segments. Interoperability is not driven by one industry segment or initiative. So with that, I know that we have gone over. Vince, are you able to?
Yeah, I'm going to keep it very quick to keep to the time commitment here. Dave Castle said it great. Creative, interesting things need to get out into the market. So what we have created is a place to be able to create. This is an example of the desktop where, in this example, the ability to create use cases, services, case studies, link them all together, and then most importantly, find a way to be able to search for them, to be able to discover something. If you only know a name, if you're looking for COVID, right, you might end up with a use case that an HIE is doing or a creative work that the Direct Trust is doing. So I'm going to skip this demonstration because of the time so much. Where we are right now in the stream of time, though, is that everybody will on the Discover Alliance website, we are now soliciting early adopters for the platform. The board members are all moving forward with submitting their cases and use cases and case studies. There will be content there, and we now invite the audience to participate. So, Lee, just because of the time, I'm going to keep it that quick and turn it back to you.
Thanks for the overview, Vince and Jenna. Hey, Jenna, so if somebody wants to get to Discover Alliance to find out more, to become an early adopter, the website, you want to give us the website?
Yes, just go to discoveralliance.org, and I believe what Vince was showing there, discoveralliance.org/services. And perfect. That's kind of our landing page to sign up for additional information or demo.
Great. So I would like to thank you both, and I want to thank the panel as well. And Jenna, you already talked about thanking all of our sponsors, our panelists, Kelly Thompson of Chic, Scott Stewie of Direct Trust, Paul Wilder of Commonwealth, Chuck Jaffe from HL7, Dave Castle from Care Quality, and John Rancourt from ONC. I want to thank the panel for a really great conversation, and thanks to Discover Alliance for really hosting this town hall virtual meeting, and thank you to all of you for participating. We'll look forward to talking to you again in the future. Take care, everybody.